We are presenting a case of a patient with a history of recurrent missed abortions. She is now 6 weeks pregnant based on her last menstrual period. The goal of the scan was to confirm intrauterine pregnancy, assess viability, and evaluate for any uterine anomalies, given her obstetric history. On scanning, the uterus appeared abnormally shaped with a fibrous echogenic band running along the midline of endometrial cavity, partially dividing it into two horns. This is a classic feature of septate uterus, a Mullerian duct anomaly, and often implicated in recurrent pregnancy losses. The gestational sac was located in the left horn of the uterus, confirming that implantation occurred within the endometrial lining. The sac appeared regular and eccentrically placed within the horn, consistent with a normal implantation within a septate uterus. Gestational sac appeared to be oval-shaped, surrounded by a healthy decidual reaction. Yolk sac is visualized, and a fetal pole also seen, measuring consistent with 6 weeks gestation. However, no fetal cardiac activity was noted at this stage. In the right horn of the uterus, a well-defined hypoechoic mass is identified in the interior wall, suggestive of fibroid. It is homogeneously hypoechoic, located in the interior myometrium near the fundus of the right horn. No internal vascularity or degeneration seen on color Doppler. This appears not to be distorting the endometrial lining of the right horn. Both ovaries were visualized and appeared normal in size and echotexture. No ovarian cyst or abnormalities or adnexal masses were seen. There was no free fluid in the pouch of Douglas. Our immediate clinical concern is the viability of pregnancy, the absence of fetal cardiac activity, which could indicate a missed abortion. However, in some cases, especially with uncertain dating or late implantation, it may be too early to confirm non-viability. What are the next steps to be taken? Repeat TVS to assess the development and cardiac activity after 1 week. Serial beta HCG measurements to track pregnancy and progression. Patient counseling regarding possible pregnancy loss, but also hope for an early gestation to evolve. If there is no cardiac activity on repeat scan and serial beta HCG levels are plateauing or declining, a missed abortion can be diagnosed. What are the management options? Expectant management: allow natural expulsion if the patient prefers and is stable. Medical management: misoprostol to induce uterine evacuation. Surgical management: DNC or suction evacuation, preferably in recurrent loss for histopathology. How do we manage septate uterus? The septate uterus is the most common congenital uterine anomaly and is strongly associated with first trimester pregnancy loss. Corrective management after this pregnancy, requiring hysteroscopic metroplasty, which is septum resection. This is minimally invasive and it has a high succession rate. The fibroid seen in the right horn is intramural and currently not distorting the cavity or causing symptoms. For future pregnancy planning after surgical correction of septum, the outlook for future pregnancy is much improved. We recommend early first trimester scans in all future pregnancy. Consider progesterone support in luteal phase or early pregnancy, especially with recurrent loss. Treat any thyroid, autoimmune, or thrombophilia issues if suspected. Referral to reproductive endocrinologist may be appropriate in some cases. Once the septum is corrected and fibroid is managed conservatively, chances for a successful pregnancy is excellent. Thus, we conclude that this case highlights the value of early ultrasound in high-risk pregnancy. Septate uterus is a treatable cause of recurrent pregnancy loss. Timely diagnosis and appropriate surgical correction can restore normal fertility. Patient-centered approach and close follow-up are key to this case. Please remember to follow and subscribe our channel. Thank you.